Really great to be here. I think it's my first in-person conference. I want to say thanks to Rupert and Sarah for organising. Yeah, as Rupert said, something completely different. We're essentially talking about a clinical trial, but we're not talking about the clinical trial results in the main, because I think I might have bored quite a lot of the people here about those already. But it's nice to hear David at the back had not heard of those results. So happy to take questions on those. We've called our talk Beyond Standardized Symptom Scales. So basically, this is reporting a secondary analysis and a qualitative analysis from a clinical trial looking at ketamine-assisted psychological therapy in alcohol use disorder. Yes, it's also different because we're not talking about depression. So just our conflict of interest statements. I receive funds from Open Life Sciences and have consulted with organisations, but the work presented here was funded by the Medical Research Council and the Society for the Study of Addiction. And just starting kind of at the end to say thanks to a lot of people involved in the study. So the people on the left are a lot of the people, well, some of the people involved in the trial, although not everyone. I know says Anya is at the back, who is also involved. This picture isn't there. And then on the right, the co-applicants, Brigitte Brandner's an anaesthetist, and Ingrid Hughes, a psychiatrist, and Val Cohen, psychologist. And I put Marva, and then the people underneath, Joe there, who was involved in the qualitative study. I put Marva in the middle because whilst I led on the clinical trial, this is really Marva's PhD work. So that's why she's really big, and I'm sure she'll be able to answer a lot of the questions. So yeah, just to give you a little background to the trial upon which these results we're going to talk about were sort of based. We set out to look at ketamine both with and without psychological therapy in alcohol use disorder. And we did this because there was some preliminary evidence from some studies in Russia giving 3 doses of ketamine and group psychodynamic psychotherapy suggesting massive reductions in relapse of 40% at 12 months. So I thought that was really promising. Also at the time, there hadn't been any studies looking at ketamine both with and without psychological therapy. So that's what we set out to do. I'm not going to talk too much about the therapy part today, but essentially the design, we randomized people. So there were 96 patients in this study, and we randomized them to receive either 3 infusions of ketamine, and that was 0.8 milligrams per kilogram, so slightly higher than the antidepressant dose. And this was because we reasoned there's some cross tolerance with people with alcohol problems due to NMDA receptor actions of alcohol. And our comparison condition were 3 infusions of placebo, which was just saline. So 48 people in both those groups. And then this was a factorial design. So within those 2 groups, we randomized people to receive psychological therapy or control. But I won't talk too much about that, focusing instead on our secondary analyses. This is just to give you an overview of the study and the kind of key time points. So we required people to be abstinent from alcohol when they were randomized into the study. And so they had to cut down even before screening in some cases. Yeah. Oh, sorry, is it not high enough? Ah, okay, yeah. There we go. Is that better? Better? Oh, yeah, sound louder to myself. That's all good. Okay. I'll try and speak slowly as well, which is one of my issues. So yeah, so when people were randomized, they had to be abstinent from alcohol. And then they went through the treatment protocol, which was essentially 7 sessions of psychological therapy of an hour and a half in duration, with 3 ketamine infusions within that. And so the way we did that, people came in for a therapy session of an hour and a half, and then straight afterwards they had an infusion of ketamine, and they came back 24 hours later to have another session of therapy, which was in a kind of very crude way trying to target some of these plasticity effects and time the therapy when we thought the neuroplasticity was its greatest. And so that process, so that was 7 sessions, took around 4 weeks, although people were allowed to have up to 3 weeks between their treatment sessions. And then people came back for a final therapy session, and then they came in for a 3-month follow-up and then a 6-month follow-up, and that's where we assessed our primary outcomes. That was a kind of broad overview of the study. And what we found, just to talk, and these results, as Strate said, were published earlier this year in the American Journal of Psychiatry. Essentially, we had co-primary outcomes of percentage days abstinent from alcohol at 6 months, and then relapse, which we defined as no heavy drinking days over a 6-month period. And so we did find a significant difference between ketamine and placebo. I don't know if is that pointer working. Oh, done something weird. No, I won't try and use the pointer. But essentially what we found, so it was in the pattern that we'd hypothesized. So we found the greatest reductions or increases in abstinence in the group given ketamine and therapy, then ketamine and education, then placebo and therapy, and then placebo and education. But we didn't find a significant difference in having no heavy drinking days over the 6-month period. So that was a dichotomous outcome of just any heavy drinking days or not. But we did find, so onto our kind of secondary outcomes, we found significantly lower alcohol craving with the greatest reduction in our group given ketamine and therapy at 6 months, but particularly a significant difference between ketamine and placebo. And similarly, in our ketamine versus placebo group, we found lower levels of depression on the BDI at 3 months, but not at 6 months. So our alcohol differences were observed at 6 months, but the depression was only observed at 3 months. And we have some other secondary outcomes. And all of that was very interesting, but obviously a clinical trial is a lot of work for the patients and also for the researchers, and we wanted to make the most of our data. And so one question we were really interested in, although in a much simpler way than Carlos Duarte or Lisa Montaggio's talk, we wanted to see if there was anything in our data that could predict treatment response to ketamine. And by treatment response, this was the reduction in alcohol. So what we did was look at studies looking at clinical predictors from treatment-resistant depression. And a few clinical predictors have emerged over time. So one of those is body mass index, where higher BMI indicates a greater acute response. Another one that's emerged, a history of suicide, so with greater number of suicide attempts being associated with a greater antidepressant effect. One of the strongest clinical predictors to have emerged is the presence of a family history of alcohol problems, with a family history of alcohol problems being associated with a greater antidepressant effect in a number of studies, and an extended antidepressant response in one of the most recent studies. So we thought that was particularly relevant for this group, and that was something that we could look at in our sample. And we were also interested whether there were particular changes in symptoms that mediated treatment outcomes in terms of alcohol outcomes. And we had a number of subjective scales. So what we set out to do this, we thought a principled way to do this would be to reduce our data. So we're using a factor analysis. So we selected these scales relating to psychological factors. So we used the brief psychiatric rating scale, the Hamdi affect depression inventory, as psychotomimetic states inventory, and the Spielberger trait anxiety scale and the POMS. And then we subjected these to a factor analysis. So we enter there, you enter all the items and look for factors that hang together in terms of those items. So the data kind of, then those factors emerge. I'm sure most of you are probably familiar with the principle of factor analysis. And actually from this data set, 3 factors emerged. There seemed to be the one accounting for the highest amount of variance was anxiety. And these are the 2 items that loaded most highly onto this factor. These were I feel frightened and I feel worried. So we attribute, so we decided this was anxiety by looking at the factors that, by the items that hang most heavily or load most heavily on these factors. So it's important to say that. The second factor that emerged, the items that loaded most heavily on that were I feel guilty all of the time, I blame myself for everything bad that happened. And there were other factors within that that seemed to suggest this was a factor indicating repetitive and negative thought or repetitive self-critical thinking. And then the third factor seemed to be related to anhedonia, by the fact that the items that loaded most heavily on that were, it's hard to get interested in anything, I can't get pleasure from the things I used to. So we took these 3 factors and then looked at these in a moderated mediation analysis using family history of alcohol problems. So just to give you an idea of the demographics of our sample, so this is just the ketamine group versus placebo, so with 48 patients in each group. So these people are in their early to mid 40s, which is quite consistent with treatment seeking in alcohol. We had more males than females, again, so around a third of the sample were female, which is consistent with their presentation. About half of our sample had a history of depression, and consistent with disorder, that's 50% genetically heritable, about half of the sample had a family history of alcohol problems. To their alcohol use, so patients on average met, these are the number of DSM criteria they met. So they met criteria for severe alcohol use disorder. And their heaviest recent alcohol use, and this is in grams, which equates to, I guess, around 50 to 60 British pints per week. So they were high alcohol users. And that was their heavy use. And then at screening, they'd managed to reduce down. So that's, as I mentioned, they had to be abstinent when they entered into the trial. So what do we find? So taking these factors and looking at differences over time between placebo and ketamine. So on the left is, I'm going to try pointing again. No. Does it? No. I'll just leave that. Oh, is that like that screen? Is that? No, I know it doesn't matter. I can just. Oh, is it that one? Oh, thanks. It's kind of like a spotlight. Yeah, so on the left, anyway, is repetitive negative thinking, as we call this factor. And as you can see, at 3 months only, there was a significant difference between the placebo and ketamine groups in this factor, but not at the end of treatment or at 6 months, where we saw significant differences in drinking outcomes. And the same for anhedonia factor, again, at 3 months. And for anxiety, there were no differences between ketamine and placebo across the treatment duration. When we looked at family history of alcohol use disorder as a moderator of this effect, and what's quite interesting, you can see for people who have no family history of alcohol problems in blue, a similar effect both for repetitive negative thinking and anhedonia. We can see that there's very little difference between placebo and ketamine for people without family history of alcohol problems. But for those that do, you can see much reduced repetitive negative thinking and anhedonia in the group given ketamine compared to placebo. So you can see the effect seems to be confined to, this treatment effect seems to be confined to people who have a family history of alcohol problems. So yeah, the family history, so people with a family history of alcohol problems moderated the effect of ketamine on repetitive negative thinking and anhedonia. But importantly, it didn't mediate the effect on overall drinking, so on our overall alcohol outcomes at 6 months. And then the slightly complicated slide was looking at craving and family history of alcohol problems and moderating our primary outcome. So you can see in the top left, similar to rumination or repetitive negative thinking and anhedonia, I would see the similar pattern where people without a family history of alcohol problems, there's no difference between the placebo and ketamine groups. But for those that do, there's much reduced craving in the ketamine group, and these are craving scores at 3 months. And then we put that into a moderated mediation analysis. We find that craving actually did mediate the relationship between drug condition and the percentage of days abstinent at 6 months. So you can see from the graph, the positive family history graph on the right, at the top in blue is the ketamine group. These are people with a family history of alcohol problems, and the shorter line indicates lower craving overall, but also that ketamine seems to have disrupted the relationship between craving and abstinence. So in other groups, increased craving results in decreased abstinence, but that's not the case for the ketamine group, who have much lower levels of craving if they have a family history of alcohol problems. But this is not observed for people who don't have a family history of alcohol problems. So we thought that was interesting. So as an interim summary before I hand over to Marva, we found from this data set, which is a clinical trial of people with alcohol use disorder, emergent transdiagnostic factors of anxiety, repetitive negative thinking and anhedonia. We didn't find any differences in anxiety across our trial, but lower anhedonia and repetitive negative thinking at 3 months post-ketamine compared to the placebo group. But this wasn't observed at 6 months, where we saw our drinking outcomes. And we found lower repetitive negative thinking and anhedonia following ketamine, only that this effect was confined to those people who had a family history of alcohol problems. So it seems that family history of alcohol problems, and for craving, the family history of alcohol problems actually moderated the relationship between ketamine, but then this mediated the relationship between our ultimate treatment outcome, which percentage days abstinent of alcohol. So we're interested to explore other predictors, things like BMI, but we're also interested in the reasons for this relationship between family history of alcohol problems and these measures. I mean, I think it's quite interesting. I suppose there's potentially a very genetic component to this, but also people talk about the elevated levels of trauma that are experienced in people who have a family history of alcohol problems. And we know that interacts with your endogenous opioid system. So this might relate to some of the things that Carlos Sabato is saying about the opioid effects of ketamine. So I think that's something that would be great to follow up. So yeah, so thinking about other perspectives, I'm going to link over to Marve. So this is one way we can get some more out of our data, is using factor analysis to explore these emergent symptoms across multiple subjective and clinician administered scales. But something that's quite frustrating sometimes when you're talking to people who've had the ketamine experience is that it's quite difficult to capture the richness of the experience and these kind of spontaneous subjective reports in standardized measures. So Marve has attempted to do that with her qualitative analysis, which she's going to talk to you about now.
Thank you. Can you hear me okay? I think this is working. Yeah. Yeah, okay. Thank you, Celia. So in this qualitative study, we aim to explore participants' experiences of taking part in a ketamine trial at various stages. So prior to taking part, during the acute and during the acute ketamine experiences and the long-term effects of the trial, as well as their current drinking levels. So we interviewed 12 participants who received ketamine in this clinical trial, and we asked them about their experience of the ketamine infusions, the long-term effects of the trial on their relationship with alcohol, and so on. And we analyzed the data using reflexive thematic analysis. So we identify 6 themes. The first one related to the multifaceted motivations participants reported for taking part in a clinical trial of ketamine. The second one was about the importance of set and setting as influential in determining the acute ketamine experiences. And then we had 3 themes relating to the acute experience of ketamine itself. So the first one was about the inherent contradictions of the experience. The second one was about the fluctuating and changing nature of the experience. And finally, the meaningful spiritual and mystical ketamine experiences. And our last theme related to the potentially transformative effects of the infusions and the trial on relationship with alcohol. So participants reported multiple motivations for taking part in a trial. For example, concern over their own health and alcohol use and hitting rock bottom. One participant says, I was at my wit's end, at my lowest point. I had no escape, no way out of alcohol, to the point that I knew if I carried on, it would kill me. Other reasons included altruism and wanting to help others, and the legitimacy of the trial, which is afforded by being conducted at a well-known university and hospital. So in terms of set and setting, so here we're using terminology from the classic psychedelic literature. So set and setting respectively refer to internal variables, including mindset, prior beliefs, expectations, and external variables such as the cultural, social, and physical environments. So participants' prior experiences with psychedelics or other altered states of consciousness help them feel prepared for the experience, and the clinical and carefully regulated setting of the trial appeared to also contribute to their experience, in that they felt safer and potentially minimize negative experiences. So one participant said, how extreme is this experience going to be? Is it going to be a ride from hell or something like that? And it absolutely wasn't. And that's down to the laboratory type conditions, the controlled environments. So in terms of the acute experiences, these experiences were characterized by contradictions. So nearly all participants reported dissociation or detachment from their environment, their physical body, their sense of self or the world, and seemingly paradoxical feelings of connectedness were reported as well. So a diminishing sense of self as distinct from other beings, feelings of unity with the universe. So as an example of dissociation, one participant says, my whole feeling of my body disappeared. It was like being an amoeba and just floating in space. I had no body, I was a soul. And in terms of feelings of connectedness, one participant says, what was important was my relationship with the universe and the universe as a whole. Therefore, those relationships with people and other entities, nature and wildlife, and things at that scale. Just quickly on the other aspects of the ketamine experience, these included perceptual distortions, which appear to evolve throughout the infusion. And also there were some experiences which were more meaningful, spiritual or mystical. So for example, the experience of ego dissolution were related to gaining deep insights about the meaning of life or the role of or meaning of trauma. And our final theme related to the potentially transformative effects of the ketamine and the trial. So for some people, this included a shift from more uncontrolled to controlled drinking, whereby they were able to remain abstinent for longer periods of time or drink less alcohol. So one participant says, I still drink, but I'm capable of having 2, 3, 4, 5, 6 days where I'm just not bothered about it. For others, there was a reduction in their craving or urge to drink alcohol. I feel much less desire to drink now than I used to, and I think I actually enjoy it less now. And for some people, there was a change in their motivations for drinking, from drinking to cope with negative emotions to drinking for social reasons. So it's just more sociable drinking now, one participant says. So for some participants, these experiences, the transformative effects on their relationship with alcohol appear to be related to some of the acute ketamine experiences, particularly dissociation and feelings of connectedness. So one participant reported that overcoming this near-death-like experience of ketamine dissociation was helpful in terms of coping with problems in life rather than drinking. So they said, moving onwards in life, every time I get something that's quite testing or a problem, I just say, well, a couple of months ago, I was just white. They're referring to white light. So how bad can this be? At least I'm not white, at least I've got a body, at least I'm alive, kind of thing. And in terms of feelings of connectedness, another participant suggested that reduction in self-absorption and feelings of unity with the universe was related to their changes in their relationship with alcohol. So the sense of moving, the sense of oneness that I felt, and the sense of moving away from focusing on the worries and the small stuff is helpful in terms of improving my relationship with alcohol, because I think I use alcohol as a self-medication and as a blocking and avoiding mechanism. And I think feeling those issues are less prevalent or less important means I feel less motivated to drink. So just briefly on the relationship between the themes. So as I said, set and setting were really important in the acute ketamine experiences, but because participants had more than one infusion, experiences of the first 2 infusions also contributed to set and setting as expectations. And some of the acute ketamine experiences were reported to be related to the transformative effects, particularly feelings of connectedness and association. And again, some of the transformative effects contribute to expectations from subsequent infusions. So to summarize, set and setting was found to be an important factor in determining the acute ketamine experiences, and particularly the clinical setting of this trial seemed to be more reassuring to participants who were naive to ketamine mostly, and also the trusting relationship with staff and preparation was really important. So we reported participants' experience of feelings of connectedness and also ego dissolution or mystical experiences, which are not reflected by characterization of ketamine as a dissociative anesthetic. So we think this is something to consider. In terms of mechanisms, some participant reports suggested that experience of strong dissociation and feelings of connectedness were related to the changes in their relationship with alcohol. And this is important, well, this is interesting because when we looked at the clinical trial data, we didn't actually find a correlation between the perceptual and dissociative effects of ketamine and the percentage of abstinence, but that measure did not include a measurement of feelings of connectedness or other mystical effects, which were found to be related or mediated the therapeutic effects in the literature. So that's something to consider, but it suggests that at least for some participants, these experiences appear to be quite important. And finally, in terms of the relationship with alcohol, nearly all participants, actually all participants who did complete the treatment reported a significant change in their relationship with alcohol, but only a few of them were abstinent at the time of interview. So we might need to consider perhaps outcomes beyond abstinence and relapse rates based on participants' motivations and expectations from treatment, as these can be quite important in determining this. Yeah. Yeah, I think I flew through that. Just briefly on strengths and limitations. So we tried to provide an insight into the subjective experience of participants who received ketamine in a clinical trial of alcohol use disorders. And we conducted interviews about 2 years after their participation, but the experiences were reported to be memorable and they were able to provide a detailed description of their experiences. One limitation is that there might be some non-specific factors that explain the change in relationship with alcohol that we've reported here, including things like rapport with the therapist and the care and attention received during the clinical trial. But myself and my colleague who conducted the interviews were not known to the participants, so this might have minimized some of the demand characteristics. So yeah, thank you.
Thank you. It's interesting. Any questions?
Hi there. Thank you for that, Sagar Farid from Toronto. I have actually two questions. First of all, for the second presentation, were you interviewed only the people with the ketamine, or did you, or did you interview people who got a placebo?
So it wasn't just people who did well with ketamine, but we did interview only the ketamine participants because we were particularly interested in the ketamine experiences. But the way we approached it was, it wasn't about the outcomes. We didn't necessarily know the outcomes at that point. So there was one participant who actually didn't complete the treatment because they had one person we interviewed who didn't complete the treatment because they, I think they had...
They never met the inclusion criteria.
Yeah. So there was one person who only had one ketamine infusion and didn't finish the treatments, and they actually had some negative experiences. So predominantly they did have more positive experiences, but we didn't pre-select for that. Yeah.
So
I think was there another question?
My name is Antonio Metastasio. I was wondering if any of the participants were on any alcohol relapse treatment, pharmacological treatment. I'm asking this question because the first speakers stated that naltrexone seemed to have a negative impact on ketamine treatment, but also because it modulates NMDA receptor. I think particularly the second molecule could be quite interesting. With ketamine.
No, that's a good question, and that was an exclusion criteria for the trial, that they were on other relapse prevention medication. Interestingly, there's a study, John Crystal is meaning Patakis did a study, I think it's only on 5 patients with alcohol use disorder and depression, showing that naltrexone there doesn't block the antidepressant effects, which maybe is a different pattern in alcohol use disorder. So I think that's quite recently come out, the study, but yeah.
Hi, I'm from Sweden. Just a short question. How was the abstinence measured? Was it like a blood sample or?
Oh, no, timeline followed back, which is, but we did also, they wore a Scram X monitoring bracelet. I don't know if you've seen them. It looks like a tag. So like you're on day release from prison. So they were quite stigmatizing. This ankle bracelet that's huge, and it measures the alcohol excreted through sweat. So it takes a measure every 30 minutes. So we use that to validate the timeline self-report measure. But yeah, the actual primary outcome was based on just timeline follow back, which is where you just go back over time and ask people how much they've drunk based on drink diary. Yeah. And that's the standard measure in alcohol clinical trials, which is, yeah, it's not ideal. But luckily now there's kind of advances with wearable tech that are a little less stigmatizing than this gigantic bracelet that we used, which was actually a bigger cause of dropout in the trial than the ketamine. So it's not great.
I think we have just one last question from the remote audience from Theo Barjotas. At baseline, did those patients with FHP who seem to have benefited more from the ketamine effect on depression drink more heavily than those without?
I don't think there was a difference. I think I looked at the DSM-5 criteria, and I don't think there was a difference in terms across the family history, positive and negative. So, yeah, I don't think we specifically looked at drinking levels, but I guess if we consider the DSM-5 criteria, there were no differences between positive and negative family history.
It did look like they scored more highly on, but it wasn't on that anhedonia and repetitive negative thinking at baseline compared to
Thank you very much. And
Okay.
I think we can have some tea.